Welcome back, everyone. We're going to get started with our next presentations. Sorry to interrupt lunch, but we do want to stay on schedule. Excuse me, everyone. We're going to start with our afternoon presentations to make sure that we stay on track. We're going to change up some more things this afternoon just to keep you on your toes, but for now, we're going to move forward with our presentation that we moved to during lunch because we had such great dialogue and questions this morning. We ran a little bit behind and we wanted to make sure we took a lot of questions and had some good dialogue amongst all of our attendees. So for now, we're going to move on to our next presentation. As some of you know, earlier this year, ARDA did some beta testing and launched its first patient-powered research project called ARNet, which stands for the Autoimmune Research Network. Our next speakers, Tom Christie and Dr. Marcella Ferrata, will be presenting on ARNet, and if they can join me on stage. Tom is the chair and CEO of Relapsing Polychondritis Awareness and Support Foundation. He's also the administrator of ARNet, and Dr. Marcella Ferrata is a researcher who knows just how important it is to have access to patients with rare diseases to advance that research. So please welcome Dr. Ferrata and Tom Christie. Thank you.
Good afternoon. Welcome. Great to see a nice crowd turn out for this. We're going to change the subject for a little bit and talk about something other than insurance and politics. We're going to talk about data. And like the sign says, you know, God we trust. Did everybody else bring your data? I didn't think so. What I want to gain out of this little short presentation is to help you understand that the power that data or information can provide to help you, because data is information. And the ARNet program is the target of my conversation. Dr. Ferrata will be addressing just registries as a whole. The ARNet application itself is what we call in my profession an anonymized or de-identified patient registry, de-identifiable. If you could go to the next slide, please. By de-identifiable, I mean you have options to not have the patient name and demographic information in a record set that you might give to a researcher or anyone else that might want to look at the data. Each record has a control number, and that's what is used initially to identify the patients. The goal is to turn data into information and information into insight by apprehending the inner nature of things or of what we are seeking intuitively. That's kind of a big mouthful. That's a quote from Ralph Kimball, the guru of database development. When I say the inner nature of things, by apprehending the inner nature of things, it's simply a way of saying, here's what I want to see, and I want to capture that data, and I want to be able to use it intuitively and quantitatively to help accomplish what I'm seeking to find out. Patients volunteering their data, or who is ARNet? The researchers qualifying patients for further information. It's not a terribly complicated process. We have patients who are willing to fill out the registry form. We have the honest broker system, or gatekeeper system, if you will, and that's me. And then you have the researchers involved. I'm not going to go into the whole breakdown of the process about anonymity and how things are controlled. But I do want you to understand that essentially when a researcher is looking for a patient or patients that have perhaps, the one we're working on is autoimmune hepatitis, having an extremely difficult time finding anyone. He contacted us, and we were able to come up with 293 names for him, and he only needs 14. So he was quite astounded and very happy that we could pass that many people on to the second phase of the qualifications. In order to get involved, there's a white paper in your packet that you got today. Looks like this. Everybody should have one. And again, it's a very simple process. You essentially contact ARDA, or if you have a patient advocacy group such as mine, where we have a link to ARNet on my website. For the patients that want to join into it, if you are an organization that wishes to have registry information put into our database that's autoimmune related, just contact ARDA, probably Pat Barber or whoever they mention on this handout, and we'll be happy to get you the information you need. Next slide, if you don't mind. One of the biggest questions that keeps coming up. This has been 2 years now in development to come down with what we feel is a lightweight, simple process that can be easily executed, but it's also easily scalable, where we can interact, if you will, with other data collection applications, if you will, and what we in the IT business we call it a data mart. We can connect data marts. Think of Walmart's got a warehouse and then they have stores. Well, Walmart's the warehouse and all the little stores are data marts, and they are all connected together through the same control measures and identification measures. What ARNet is not, it's not to be used for analytics. It isn't designed that way. The questions aren't designed that way. We've had a lot of people ask, can we include this question because my researcher really wants to know this? And we tell them, I'm sorry, we can extract patients for you from the database that meet preliminary qualifications. We'll send them out an email, see if they're interested in participating. You can, at that time, we can say, do you have relapsing polychondritis? If they say yes, then they are then qualified to move on into the actual survey. If they say no, then we discard that record. There's another quote from Dr. Kimball, and it's kind of our vision, which is incrementally deliver a single version of the truth based on priority. There's a ranking system for ownership in the database. Who owns the patient record that comes across the board. We have a way of identifying where that patient came from, what website they came from. And as they go through the process and once they submit it, they are automatically assigned to the organization that has that website. So we do prioritize based on kind of a first come, first served basis when it comes to extraction as to who gets, if there's any monetary exchange for the names or the data. But by single version of the truth means the latest, most accurate information that we have. Patients can update their records if they wish. But for the moment, all of the queries and all of the extractions and all of the questions essentially will be funneled through me, not only on the way in, but before it's sent back to the researcher for me to make sure that the queries are properly written and that they're producing proper results, accurate results, and that we're not violating any of the confidentiality rules of the program. So with that said, I wanted to introduce my friend and my favorite colleague, Dr. Marcella Ferrata. She's with NIAMS, the National Institute of Health. She is also assigned, and you can put the next slide up, she is also assigned to my foundation, the Polychondritis Foundation, as a federal liaison, as a medical advisor for relapsing polychondritis. After completing medical school in her home country of Colombia at the University of Ballet, she went on to further training in multiple ACGME accredited residency and fellowship training programs. She's completed internal medicine residency at the University of Miami, where she stayed on for an extra year of training in a leadership position of chief resident. She went on to complete critical care medicine fellowship at the NIH, infectious disease fellowship at Johns Hopkins Hospital, and is currently a rheumatology fellow at the NIH. She's a member, she is an American board internal medicine, board certified in internal medicine, critical care medicine, and infectious diseases, and she will soon be eligible for rheumatology. She's a member of the American College of Physicians, the American Thoracic Society, the Society of Hospital Epidemiology of America, the Society of Critical Care Medicine, the American College, and the American College of Rheumatology. She's received 9 awards from various institutions, including Mayo Clinic and the University of Miami and the American Thoracic Society. She has 12 peer-reviewed publications, 11 grand round presentations on relapsing polychondritis in just the last year, 5 case reports, and 2 book chapters, and 24 poster presentations, among other things.
I'm going to hide under the table.
And as though that's, yeah, I mean, you see why I call her my favorite, of course, you know, person. And as though that in itself's not enough, she's also a relapsing polychondritis patient. Okay. And being from Colombia, she speaks perfect Spanglish. Okay. Perfect Spanglish.
Okay, well, hello. And I did not hide under the table. So you were having some questions about registries, right?
I have some questions to get us started. And my first one to you is, why are patient registries so important, and why is it even more true for rare diseases?
So I think that Tom touched a little bit about what are the patient registers, but basically patient registry is like organized system where you can collect data in a uniform way. And then for patient registers, the main component is the disease, right? So it's a specific population that is defined by a disease. And patients register are very important, but more important than the registry is how the registry was planned, set up, and developed, because is going to be as good as that, right? So all the time that you spend setting up your registry, that is more important, right? Because if you don't have the correct questions or the goal of the registry, that has to be set up a priority to be able to have a register that is going to be successful and is going to give you the information that you need. Now, registers are important for all diseases because you could acquire information that otherwise is not going to be available. And for autoimmune and rare diseases, I think that is even more important, especially for rare diseases, because by having a registry, you could have a significant amount of numbers that otherwise there is no way that you can compile them. I'll give you an example. With the help of the Relapsing Polychondritis Foundation, we conducted an international survey of patients with relapsing polychondritis. This is a very rare disease. The incidence was calculated in 1986. They're very old because there is no data until now, because we're going to have new data. It was 3.5 per million. And we were able to acquire 320 answers in 6 months. And the answers that we have from that patient registry or survey that we created, they're not available anywhere else, and there are questions that are going to provide information to physicians about how patients with relapsing polychondritis perceive the disease, questions that physicians sometimes may be thinking about it, but they don't know what is the answer, such as what are the triggers of flares in relapsing polychondritis. And the other thing that you could find with registries is to have like, this is the real world, right, answers of what people are having in the community, including treatments, including outcomes, including clinical presentations. So that's what I think that patient registers are important.
Right. Yeah, like I said, data can be a really valuable tool. You know, I defy you to go out and find 320 people that have relapsing polychondritis. You will die of old age first. But, you know, it's just an example of, you know, how you can gain significant numbers. Question?
Yes, I'm sorry. I'm coming into this sort of new to learn, and you maybe would explain it, but how were you able to reach so many people and to collect that data in 6 months? Is your network so broad? Was it through NIH? Or?
So this was so we cannot send surveys from NIH because there is a rule that is like I'm forgetting the name, like paper, some rule that you cannot send. Yes. So you can. Yeah. So you can. So as an NIH employee, I was not able to send the survey to anybody, right? So I got an exemption from the IRB because who put the survey for the people to answer was the foundation. So the foundation posted the survey in their website, and they posted the survey in the support groups, and there is multiple support groups for relapsing polychondritis, and the patients self-identified with relapsing polychondritis went to the survey and answered the survey. So that is how, and that is why it's so important for any disease, not only for rare diseases, to have a very strong relationship and connection with the foundations and the support groups, from not only from the advocacy and support group and foundation standpoint, but from the researcher standpoint. It has to be a true connection, because that is how we could help each other to make the diseases better, right? That is how we can find enough patients to do research that is going to be meaningful.
Right. Social media is a very, very effective means of reaching the patient population. We have formed a coalition. My organization has formed a coalition. We have 6 relapsing polychondritis support groups in 5 different countries. And when we need patients, we broadcast out to those organizations or groups, along with our website and Twitter. And we get good results, but that's because we keep an open line of communication going with everyone. We keep everybody abreast of what's happening, you know, and keep them informed of, you know, what the end results are. Marcy, why don't you tell us a little bit about how patient registries can help the research?
Yeah, we took we took a little bit about that already, but I think that
Especially
patient
with autoimmune diseases
with
and
autoimmune
other
diseases.
reasons.
So I think that we just give you an example of how this could be very important, because again, you won't be able to have enough numbers if you don't have a registry, especially for patients with rare diseases. And I just think that that patient registers could be helpful not only for research but in other circumstances. And again, it depends of the registry. So you
Right.
define the registry, your registry, the way that you define it, but there is other registries that are also available for patients. And then the main thing is that, for example, for a hospital, having a patient registry would be helpful, because then you can see how physicians are managing the patients. Are they managing the patients accordingly to evidence-based medicine? What are the outcomes? And again, this is a real, is the real world, right? So you
Right.
get to see exactly what is happening.
Right.
And then now that we're talking about patients, and then you talk a little bit about confidentiality, but I just think that is a very important topic. So I think that maybe you should clarify what is the confidentiality in your,
sure.
Well,
the anonymity or de-identifying data is probably the foremost most asked question, especially with RNet, because it's the first autoimmune registry that we know of in the world. And over the 2 years of meetings and you know, sessions and conversations about, you know, how are we going to secure this patient data, I think it goes a lot deeper than most people realize. And it's nobody's fault. It's simply the fact that a lot of the people that are in your line of work, whether it be, you know, you're a clinician or a researcher or doing support groups or organizations, aren't familiar with the tools available, other than just the database laying there that somebody could maybe hack into or get past, you know, the gatekeeper logins and so forth. We're using a company called Global Vision Technologies, where the RNet application is actually an executable file. It is not just a flat file sitting on a server somewhere with a bunch of patient data in it. It's protected at Global Vision by firewalls and security software. That is what these people do. So if you're going to try to approach it from that way, you might as well give up, because you will not defeat the firewall and the software package that they're using to keep their servers secure. The other way we do it is at the registry level itself. Each member eventually will have their own user ID and password to access their data in the database. They will not be able to see any of the other organizations' data. They will only see theirs. They will either work on their own to develop the query that the researcher is looking for, or they can contact me if it's a complicated one, and I will help them develop it. But by agreement, no information, no query is run, and without my authorization or my clearance or my backup's clearance to say, okay, we have a properly written SQL statement here, You know, like I said earlier, it's not disclosing any information that we're not supposed to be disclosing. The numbers are right, and everything is good. And actually, we could probably help them even get some better results based on them. Just, it's what I do. I've done it for over 20 years, and I know some tips and tricks that I can do to get more results out of the same data set. So,
I just want to underscore the point of confidentiality. I think that if anybody's going to like enter in a registry, you just need to make sure that everything is protected, like in a way that, because when you answer questions in a registry, they may ask you questions that are your date of birth and information that you don't want to get it to be disclosed. So it's always very important to make sure that that information is going to be protected and your information is going to be de-identified. So you're going to be giving a number and nobody can track down who you are. So your information, it keeps private in any register that you decide to answer.
yeah, at no time will any data be looked at or delivered that has a name or an address to it. Everything in the entire registry revolves around the patient control number. Okay, and it's not until clearance is given, negotiations are made. In many cases, it's going to be the names have been purchased, or there's a purchase agreement for that information, monetary. Then at that point, they can deliver the names. It's one-time use only. Okay, it's just like any other list company basically does their business. So it's 3 tiers deep, the security is, and in the industry that's pretty good. You can go a lot more, but that's plenty. I mean, you'd have to be a spy basically to get all the way through it, all 3 layers. And again, how can you sign up for RNet? It's in the one-pager, and if there's any questions, we'll open up.
Anyone have a question on RNet? I will say that ARDA will be holding other meetings about RNet as well going forward, and of course, Tom's here all day, of course, and of course Pat Barber's here, but Virginia Ladd can also take questions about RNet moving forward. It has been the project for the last about 2 years, and so it is getting up and moving, and we appreciate Tom's leadership. Did you want to add something, Tom?
I do have live internet here too, so I can also bring the application up.
Oh, great. So then he could show you also the actual application that they designed and kind of how it's available to be used. And for our organizations, if you want to take part in the RNet project, talk to Tom too about how your data could be loaded in there if your organization's not large enough to have its own registry. But it definitely helps to have multiple diseases represented in RNet, absolutely, for researchers and others to have across disease lines.
Right.
So thank you so much,
Okay,
Tom. Thank
thanks,
you,
Steve.
Dr. Ferrata, as well.